Hello friends, welcome to today's session of our Critical Care Sunday webinars, Young India Intensivist. Today is number 84 and it's a great privilege and honor for me to welcome our speaker. The speaker today is Professor Ashutosh Nath AGGARWAL. He is head of Pulmonology at PGI Chandigarh, and he has been a former colleague and a friend from my undergraduate days. Both of us did our MBBS together. It's a real privilege to have him here with us today, and he'll be speaking on pleural effusions. So we'll take the questions in the end. Over to you, Ashu.
Okay, thank you, Tapesh, and good evening, everyone. I bring greetings from Chandigarh to all of you. And unlike the audience, I am not a full-time intensivist, so it feels nice to be talking to a different set of specialists. And thank you, Tapesh, for the opportunity to have this interaction. Let me just share my screen. I hope the screen is visible.
Yes, your screen is okay. Your video has gone off. Please put your video on.
There is some bandwidth problem here, so
okay, carry on. If it comes well and good, just keep it on. No problem.
Yeah. Okay. So today I shall be briefly
discussing. Full screen, Ashu. It's not full screen. Yeah.
Okay, so today I'll be briefly discussing pleural effusions in critically ill patients. So pleural effusions are commonly picked up in critically ill patients. However, for the most part, these pleural effusions in the ICU are small and found incidentally on routine imaging or during investigations for other reasons. In itself, pleural effusion is an uncommon reason to admit patients to ICU, except in certain situations. For instance, a large effusion which is causing respiratory compromise, or maybe a hemothorax patient needs intensive monitoring. So on the whole, pleural effusions could result from an underlying systemic condition or could be due to a local pleural disease. So one of the commonest reasons of pleural effusion in the medical ICU is left heart failure. Effusions in this setting are usually small volume, transudative, and bilateral, and may manifest especially during aggressive fluid resuscitation that worsens fluid overload. Other systemic disorders like nephrotic syndrome, liver cirrhosis, etc. may also be associated with excessive body fluid, as well as low oncotic pressures that result in pleural transudates. Sometimes peritoneal fluid collections in these or other disorders can track into the pleural space through diaphragmatic defects. And this might be a peculiar problem in patients who are receiving renal replacement therapy through peritoneal dialysis. Sedation, neuromuscular blockade, limited mobility, etc. Might also result in atelectasis of basal lung regions with focal areas of negative intrapleural pressure that result in small effusions. Infrequently, pleural effusions can also develop as a complication of ICU procedures. For instance, central lines could mistakenly enter the pleural cavity, where intravenous infusions can accumulate. Sometimes effusions related to pulmonary thromboembolism might be transudative, although more than 80% times they are exudates. The most important cause of exudative pleural effusion in the medical ICU is of course infective. This usually occurs secondary to a lung parenchymal infection and is a wide spectrum that ranges from small uncomplicated collections to frank empyema. Other systemic conditions like disseminated malignancy or connective tissue disorders are also important causes of exudative effusions. Sometimes pancreatitis might be associated with effusion, either as a reaction to the abdominal pathology or secondary to tracking of a necrotic collection or a pseudocyst through the mediastinum or the diaphragm. Other uncommon etiologies include pleural inflammation from uremic pleuritis in renal failure patients or drug-induced effusions. Again, iatrogenic reasons could cause exudative effusions as well. A typical example is hemothorax from vascular disruption during central venous catheterization or migration of feeding tubes or during a pleural tap or placement of chest drains. In addition, in surgical ICUs, subdiaphragmatic and other abdominal collections, both post-operative or otherwise, can cause protracted pleural effusions. In multiply injured patients, hemothorax is a dreaded complication after blunt or penetrating thoracic trauma. Hemothorax can also occur secondary to tracking of blood from an aortic aneurysm or from a dissection. It typically shows a pleural fluid to blood hematocrit ratio of more than 50%. Esophageal injury, either traumatic or from local disease, can result in a fistulous communication with the pleural cavity and causes accumulation of pleural fluid that is rich in salivary amylase. Reactive and transient effusions can also occur after cardiothoracic surgery in the post-operative period. Uncommonly, one can encounter a urinothorax from a perinephric collection that is secondary to obstructive urinary drainage system, or a chylothorax after injury to blockade of the thoracic duct. So how common is it? Well, the incidence of pleural effusion in the ICU varies with the screening method and ranges from about 8% for physical examination to more than 60% for routine ultrasound if one uses CT scanning as the gold standard. Unfortunately, the chest CT scan is not practical for several critically ill patients. Most clinicians will still rely on a combination of lung auscultation and portable supine chest radiography, both of which have dubious sensitivity and specificity for detecting pleural fluid. These techniques are more useful for correctly picking up larger volumes of fluid. However, they also show high positive rates, meaning you might interpret the findings as being suggestive of pleural effusion when actually there is an alternate diagnosis. Bedside ultrasonography is now being used a lot more for routine patient evaluation, and it can identify most pleural effusions, including the smaller ones that may have little or no clinical relevance. A satisfactory compromise, therefore, must be found between a highly sensitive screening method that detects fluid of little clinical importance and a less sensitive method that mainly detects effusions with a diagnosis that will affect some of our treatment decisions. So, because chest radiographs in a critically ill patient are generally obtained in the supine position using a anteroposterior projection and from portable machines, the appearance of fluid in pleural space is quite different from what we normally see in an erect film. Moreover, the quality of portable X-rays can be highly variable, and it ranges from quite good to almost totally uninterpretable. In a lying down patient, the pleural fluid will tend to layer in the dependent portion posteriorly, and therefore the typical rising fluid level or the meniscus sign is generally not visible. All we can see is increased homogeneous density over the involved hemithorax, and this can be easily overlooked on routine evaluation, especially if the fluid volume is less. With larger volumes of fluid, this radio density is greater and will obliterate the diaphragmatic borders. Unlike consolidation, no air bronchograms are seen, and in fact, the normal bronchovascular markings might still be visible through this veil-like increased density. Sometimes fluid will also collect in the apical regions of the hemithorax because that too is a dependent area in supine position. So in this one might see a kind of cap over the lung apex. A seemingly normal chest radiograph will not exclude a pleural effusion, and if there is some confusion about the diagnosis, then one can try and obtain an erect or a lateral decubitus film. So this graphic summarizes what we just discussed. So the typical pleural effusion findings are generally not seen on a anteroposterior projection in the supine position, and we generally will see only haziness on the inward side. So this is a patient with a small pleural effusion. We can appreciate the hazy opacification on the left side through which bronchovascular markings are clearly visible. Depending on where the fluid is gravitating in the supine position, we can pick some additional signs also. As I said, lung apex is another dependent area in this posture where fluid can collect. And this gives an additional dense strip along the lung apex. Like this, and sometimes, as I said, this is called an apical pleural capping. It is generally visible with the more moderate pleural effusions. With bigger effusions, this hazy opacification becomes slightly more dense. So note that despite the density, there is still no air bronchogram to suggest any consolidation. And the underlying lung markings are still somewhat faintly visible. Also, the contour of the diaphragm is completely obliterated due to slitting. But a hazy or opaque hemithorax on chest X-ray does not always imply presence of pleural fluid. For instance, this is a false positive radiograph. You can appreciate that this patient is intubated, but the endotracheal tube is sitting here in the right mainstem bronchus. And there is relative rib crowding on the left side. These features will suggest a left lung collapse rather than a left-sided pleural effusion. So apart from this, the chest CT scans are often considered the gold standard investigation to identify pleural fluid. But moving a critically ill patient to the radiology suite is often challenging, and at times it is quite risky. Sometimes you may have CT scans that have been performed as initial evaluation in the emergency room, say for severe breathlessness or polytrauma. And so once the patient gets to the ICU, you might have a CT scan available to you. The CT scan can readily detect even small pleural fluid collections. It definitely has an advantage over other investigations that it can evaluate the pleural surface better and is ideal to identify associated pulmonary parenchymal, airway, or even major vascular abnormalities. And sometimes fluid characteristics are also better appreciated on the CT scan. So this may often help us to narrow down our differential diagnosis. So this CT image shows a typical crescent-shaped or a sickle-shaped opacity over the posterior and basal regions of the hemithorax in the dependent regions, and this is suggestive of a pleural effusion. In this section, we also see consolidation in the lateral segment of the right middle lobe. So this patient is likely to have a small and complicated right parapneumonic effusion. This CT scan shows bilateral pleural effusion. So you can see these crescent-shaped opacities in dependent areas on both sides. And the lungs, in addition, show extensive smooth septal thickening. And also there is some areas of patchy peripheral ground glass opacification like here. So these features are typical of left ventricular failure, which is a common cause of bilateral transurative pleural effusion in the ICU. This CT scan shows a large left pleural collection, which looks quite hyperdense. This suggests say presence of blood in the pleural cavity. We can also see some displaced rib fracture on the left side. And so overall, these findings will look like a hemothorax that is secondary to a blunt thoracic trauma. This is a representative section from a CT pulmonary angiography study. The right main pulmonary artery here is almost completely occluded by a thrombus, and there's a small right pleural effusion as well. So this effusion is most likely due to the pulmonary thromboembolism in this patient. So you can see that sometimes the CT scan can also help you to pick up the diagnosis in some patients, apart from just showing you the pleural effusion. So despite all its good points, CT scans have several drawbacks for critically ill patients. And as I said, the most important is the burden of transporting these patients for radiology. On the other hand, thoracic ultrasound offers the patient-oriented benefits of portability, simplicity, and lack of ionizing radiation. It can also be repeated multiple times as per need. So thoracic ultrasonography has been shown to have high diagnostic accuracy in identifying effusions, and a few algorithms also exist to approximate the volume of fluid from ultrasound dimensions. So similar to chest CT scans, these ultrasounds can also give some information about the complexity of effusion based on the echogenicity of the fluid and the presence of, say, particles or septations within the fluid. All of this has the potential to narrow down our differential diagnosis as well. Also importantly, ultrasound has the potential to augment the technical performance of any diagnostic or a therapeutic intervention, as it can provide visual guidance for thoraccentesis. As a bonus, point-of-care ultrasound may sometimes pick up the coexisting cardiopulmonary conditions, and this also can be of sometimes diagnostic significance. Ultrasound, therefore, is largely believed to be superior to chest radiography and almost comparable to CT scanning for the diagnosis of pleural effusion. I will not go into the details of point-of-care thoracic ultrasound in the ICU setting, which is a huge topic in itself. I'm sure that several among you are already using this test routinely for your patients. I would just point out that either a phased array cardiac probe or a curvilinear probe working at frequencies below 5 megahertz are more commonly employed to evaluate the pleural effusion in ICU. Several experts feel that the phased array probe is better due to its smaller footprint, and this allows easier examination between the rib spaces. Either of these probes has sufficient penetration to visualize the fluid as well as some of the deeper structures, and one needs to sometimes scan at multiple locations over the chest wall to get the complete picture. For visualization and quantification of pleural fluid, especially if the fluid volume is small, the ultrasound is best placed around the intersection of the posterior axillary line with the rib space between the 10th and the 12th ribs. This might sometimes be technically challenging in critically ill patients who cannot be freely moved, and sometimes there is very little space between the patient and the bed mattress. So sometimes this might pose some difficulty. So pleural effusion on thoracic ultrasound gets depicted as an anechoic or a hypoechoic zone between the parietal and the visceral pleural layers. It is important to delineate the boundaries of this region to confirm that the fluid is actually in between these two pleural layers. So pleural fluid will reside in an area that is bounded by the chest wall, the diaphragm, and the partly collapsed lung tissue. The diaphragm can be located by identifying the subdiaphragmatic landmarks like the liver, spleen, and kidney, and then sliding the ultrasound probe slightly cranially. In addition, one can also document the dynamic respiratory movement of the lung surface or the diaphragm adjacent to the fluid, or maybe even the movement of hyperechoic structures or debris within the hypoechoic pleural fluid. In particular, if one wants to put in a needle into the pleural cavity, then these landmarks and assessments also improve the safety because they minimize the risk of lung injury or even of inserting the needle outside the pleural cavity. So this is an example of a B-mode ultrasound on the left side. So the diaphragm is visible as a hyperechoic band over the spleen and kidney in this section, and a bit of collapsed lung is visible superiorly. This fluid is quite hypoechoic, and this suggests a relatively clear and uncomplicated pleural effusion in this image. This is another representative image from the right side, where the diaphragm can be identified just above the liver. So this is the liver, and you can see this structure is the diaphragm. And in contrast to the previous image, the fluid here is not uniformly hypoechoic. And we can appreciate a few hyperechoic bands that are running across the pleural space. This is probably due to some of the fibrinous septate. So this most likely will represent a more complex pleural effusion that has started to loculate. In addition to identifying the pleural fluid, you can also roughly estimate the pleural fluid volume, and this can be done through several formulae. A commonly used one is based on measuring the distance between the visceral and the parietal pleural layers. This is shown here as C. And this distance you measure in millimeters and multiply this by 20. So this gives you a rough volume in milliliters. And one study also found that if this distance is more than 50 mm at the lung base, then the pleural fluid volume is at least 500 ml. And another estimate is based on measuring the distance between the diaphragm and the base of the collapsed lung. So this is here shown as B. And this distance again is measured in millimeters, and you multiply this figure by 16 to get the approximate amount of pleural fluid. So for all such calculations, you have to take some care that you don't angle or tilt the probe so that you obtain a truly transverse section. So it is clear that ultrasound is quite helpful in diagnosing pleural effusion as well as sometimes in identifying its important characteristics. It can additionally assist in guiding diagnostic or a therapeutic pleural tap as well, as it can accurately determine a relatively safe site to put in a needle. So physical examination is rather poor for this purpose, especially if the effusion is small or loculated. So normally now ultrasound guided pleural taps are recommended, and they can either be performed under real-time image guidance, or we can just determine the depth of safe needle penetration and mark the site of needle insertion superficially over the chest wall. So in either case, this is considered as being ultrasound guided. So because of this this guidance, the pleural aspiration carries a high margin of safety, and complications like pneumothorax become uncommon even among patients who are receiving mechanical ventilation. Another specific advantage of the ultrasound would be that when pleural effusion is not free, but it is loculated. Here again, ultrasound can facilitate a targeted insertion of a drainage catheter into the pleural cavity. Now coming to a diagnostic pleural tap, the most important thing to remember here is that a diagnostic pleural tap is not always needed. And just because we have identified a pleural effusion does not mean that we automatically need to tap it for diagnosis. And I will elaborate this more in the later sections. The other important thing to note is that pleural aspiration is safe in critically ill patient, provided some of the basic precautions are followed. So, as I said earlier, experts will uniformly recommend aspirating pleural fluid only and only under ultrasound guidance. And this is to improve safety of the procedure. This procedure is safe among those who are receiving mechanical ventilation, even though the risk of pneumothorax might be marginally greater. It is also important to be ready to do a pleural tap whenever needed, because in one study from a French ICU, routine thoracentesis altered the diagnosis in about 45% patients. And more importantly, it changed the management in around 1/3 of these patients. So it's not that pleural taps should never be done. They need not be done in all patients, but wherever needed, you should not shy from doing the investigation also. But more important than being ready for the pleural tap is to understand when not to tap. In general, we can safely observe effusions which occur secondary to fluid overload status, especially if they are small. Similarly, small effusions in the early post-operative phase, say after a cardiothoracic or abdominal surgery, also will not require any intervention, especially if there are no respiratory symptoms. Also, we can safely observe small pleural effusions in patients with pulmonary thromboembolism, especially if there are no significant lung parenchymal abnormalities. So when should we actively go for pleural fluid sampling? Generally, a diagnostic pleural aspiration is most commonly considered for patients who are suspected to have pleural infection, secondary to pneumonia, or among those who are suspected to have a malignant pleural effusion. It is often also ordered if there is uncertainty about the etiology of the effusion. One can also tap the fluid if the patient with pleural effusion shows clinical deterioration during a period of observation, or if the effusion is persistent and large and is resulting in significant symptoms or derangement of gas exchange. The overall algorithm for pleural fluid analysis in critically ill patients is largely similar to that in other situations, and a battery of tests is usually ordered. The most important thing is to determine if this fluid is exudative or transudative, and the standard light criteria are used for this purpose. We also evaluate the total and differential pleural fluid counts to find if the fluid is dominantly neutrophilic, lymphocytic, or is bloody. Other basic investigations will include pleural fluid glucose, gram stain, and bacterial culture, because these results have an important bearing on the decision for any subsequent therapeutic drainage. Depending on the clinical setting, we can also do certain other relevant tests as and when required. So based on the clinico-radiologic evaluation with or without pleural analysis, we can try and figure out the most likely etiology of pleural effusion. So amongst these, the cardiac failure has been reported as the commonest cause of pleural effusion in several studies on critically ill patients. The effusions are related to increase in pulmonary venous pressure, and the fluid collects mostly bilaterally and is small or moderate in volume. Clinically, one can identify other signs of fluid overload or cardiac dysfunction. For instance, imaging may show signs of pulmonary edema and cardiomegaly, and the severity of this edema generally correlates with the presence of effusion. Similarly, echocardiography can confirm the left ventricular dysfunction. This effusion is almost always a transudate, although sometimes vigorous diuresis can slightly increase the protein content of the fluid. However, if the diagnosis is clear, a diagnostic tap is generally not indicated, and the effusions will usually resolve with treatment that is aimed at diuresis and afterload reduction. Another common cause for transudative effusions in critically ill patients is hypoalbuminemia. The pleural fluid is related to reduced oncotic pressure in the blood. The diagnosis is often presumptive only. Most patients are largely asymptomatic, and although some might manifest features of generalized edema. Importantly, these patients have low fever and do not have any findings that suggest cardiac dysfunction. This effusion occurs at significantly low levels of serum albumin, usually below 2 grams per deciliter. It is almost always bilateral, small or moderate size, and no specific intervention is generally necessary. The effusions usually tend to disappear as the serum albumin levels are built up. Iatrogenic causes should also be kept in mind in critically ill patients. In particular, extravascular migration of central venous catheters into the pleural space can be associated with effusions. More commonly, it is because intravenous fluids that are infused through these central lines end up in the pleural cavity. Therefore, the nature of the intravenous fluid and the volume that is administered, these things determine the pleural fluid characteristics. Sometimes the injury can cause leakage of blood into the pleural cavity, and this can manifest as a hemothorax. If catheter migration punctures the lung also, then there could be an associated pneumothorax as well. The definitive management includes taking out the misplaced catheter as early as possible. In general, nothing else needs to be done, and drainage is recommended only if there is hemothorax or the large volume of fluid has resulted in respiratory distress. Pleural effusions may also be commonly associated with community-acquired or hospital-acquired pneumonia. In the ICU, this pneumonia may manifest as new onset fever with purulent respiratory secretions, or sometimes only as fresh alveolar infiltrates on chest imaging, or maybe higher requirement for mechanical ventilation. Most cases of this suspected parapneumonic effusion or empyema should be sampled under ultrasound guidance. So this is one more or less clear indication for doing a diagnostic pleural tap. This pleural fluid is almost always a neutrophilic exudate. If the effusion is small and free-flowing, then therapeutic drainage is generally not required, and the effusion simply resolves with the antibiotic treatment that is directed at the lung infection. However, any fluid that is frankly purulent or shows a positive culture report should be drained. In addition, pleural fluid pH below 7.20 is the most useful predictor of a complicated disease course and is also an indication for putting in a chest drain. If pleural fluid LDH is not measured, then pleural fluid glucose values before 40 milligram per deciliter or a pleural fluid LDH that exceeds 1000 units per liter may also be predictive for the need for pleural drainage. Pleural collections that show multiple loculations are especially difficult to manage even with drainage in the ICU. On the surgical side, nearly half of the patients who undergo abdominal surgery can develop small unilateral or bilateral effusions in the early postoperative period. The incidence of this pleural effusion is higher after upper abdominal surgery. The pathogenesis of effusion could be multifactorial. Often these patients may develop ascites or subdiaphragmatic collections that can pass on into the pleural space through small diaphragmatic defects. Also, lung atelectasis, which is especially common after upper abdominal procedures, could be associated with small effusions. So if there is no feature to suggest infection, a diagnostic tap is generally not necessary. However, if it is performed, the pleural fluid is generally shown to be exudate with preponderance of neutrophils. Such effusions usually resolve spontaneously without any active intervention. As I said, lung atelectasis could be frequently associated with pleural effusions. Apart from upper abdominal surgery, other underlying factors in critically ill patients include immobility or overzealous use of sedatives and airway compromise due to airway secretions or maybe endotracheal tube blockage. So the effusion which is related here is due to local area of increased negative intrapleural pressure, and the resultant fluid is therefore almost always the serous transudate. Again, no active intervention is generally required, and the fluid dissolves slowly as the atelectasis improves. So effusions from pancreatitis may be noted in up to 20% of such patients. They are usually small and left-sided in about 60% cases, but may also be right-sided or bilateral. The fluid is an exudate with amylase values greater than that of serum. Presence of pleural effusion in these patients is often regarded as a marker of greater morbidity and adverse outcomes. In most patients, no specific treatment for effusion is needed, and the effusion will tend to resolve on its own as the pancreatic inflammation subsides. However, if the effusion persists, then one should strongly look for complications such as a pancreatic abscess or a pancreatic pseudocyst. Presence of blood in the pleural cavity is a dreaded complication on the surgical side. Such hemothorax is commonly linked to blunt or penetrating chest trauma. So if one suspects presence of hemothorax on clinical or on radiologic grounds, then a diagnostic pleural aspiration has to be immediately performed. If bloody fluid is retrieved, then the hematocrit of the fluid should be determined. So hemothorax has traditionally been defined as pleural fluid hematocrit value of 50% or more as compared to blood hematocrit. If this is so, then the patient requires immediate pleural drainage as well as regular and frequent monitoring of the drain output. If the vascular leak has sealed on its own, then the drainage of bloody fluid will eventually stop, else it will continue, and these patients will often need surgical exploration to identify and close the culprit bleeder. In general, exploratory thoracotomy is warranted if more than 2 liters of blood is drained, or if there is continued drainage that exceeds 200 ml per hour. So irrespective of the etiology of pleural effusion, the presence of pleural fluid tends to alter the respiratory system mechanics. In general, everyone presumes that the presence of fluid in the pleural space will result in a more or less corresponding reduction in the ipsilateral lung volume. It is therefore assumed that the decrease in functional residual capacity more or less equals the volume of the pleural fluid that is present. Again, it is generally presumed that fluid in the pleural space will cause some compression of the adjacent lung parenchyma. However, all these suppositions are not really borne out by the limited evidence that is available in critically ill patients. So this diagram depicts a transverse section of the thorax at functional residual capacity under normal conditions in a supine individual. So normally there is a non-hydrostatic vertical pressure gradient in pleural pressure of about 0.2 centimeter water per centimeter of vertical distance. The overall intrapleural pressure remains negative throughout, and the inflated lung is closely touching the chest wall on either side. So, but what happens when the pleural fluid accumulates, say, on the right side? Once this pleural effusion develops and collects here, the chest wall will expand outward due to a regionally increased pleural pressure, while the adjacent lung is slightly compressed. So the inflation properties of the lung and chest wall get decoupled, and the vertical pleural pressure gradient here becomes hydrostatic instead of non-hydrostatic. Consequently, it is the reduction in the total transpulmonary pressure that determines the loss of lung aeration and decrease in lung volume, especially in the dependent areas of the lung at end expiration. So in a nutshell, the pleural fluid volume will get partly adjusted by an outward chest wall expansion and partly by a loss of lung volume. Animal studies suggest that almost 2/3 of the pleural effusion volume is actually adjusted by this outward expansion of the chest wall. So what is the clinical significance of this relative uncoupling of lung and chest wall mechanics? One, the lung is not actually compressed by the pleural fluid, so this can actually be considered to be just floating on the top of the pleural fluid. Second, most of this excessive volume due to pleural fluid gets accommodated by an outward chest wall expansion. So the magnitude of changes in regional lung and chest volumes depends on the relative compliances. And chest wall compliance might actually play a more dominant role in this setting. So in patients with acute respiratory failure, the same amount of pleural fluid will tend to cause more lung compression if chest wall stiffness is increased, and less if the lung elastance is increased. So if the chest wall compliance is normal, there is greater thoracic cage adjustment with a relatively smaller effect on lung wall. So some of this discussion might explain why therapeutic removal of fluid in some of these patients fails to produce the expected range of benefit in pulmonary mechanics or in oxygenation status. Even though some experimental studies predict that the gas exchange status improves after therapeutic fluid removal, the actual observed benefit is only mild and variable. In fact, the improvement in oxygenation might theoretically result from other mechanisms. The partly collapsed lung area secondary to high pleural pressure actually acts like an intrapulmonary shunt. And since there is no aeration in this area, but the blood flow is persisting. So lung expansion can partly remove this true shunt. Secondly, effusions may also cause regional ventilation perfusion inequalities due to local hypoxic vasoconstriction or due to vascular compression from higher pleural pressures. Again, pleural fluid drainage can ameliorate some of these adverse effects. Pleural effusion can also have some hemodynamic consequences in critically ill patients. So large effusion especially can increase cardiac filling pressures and pericardial pressures, but its effects on the cardiac output seem to be less straightforward. Other factors such as spontaneous breathing activity, cardiac reserve, intravascular volume status, and lung and chest wall compliance probably interact with, and the resultant effect determines the effect of pleural effusion on cardiac performance. It is likely that hemodynamic consequences become more significant as the pleural fluid volume increases, and massive effusions can actually manifest with almost a tamponade-like effect. So how do we integrate all this information into clinical management? One, it is important to understand that the chest walls somewhat buffer the impact of pleural effusion on lung volumes and gas exchange, and therefore the overall impact of a given volume of pleural fluid on oxygenation is generally less than what one would expect. Therefore, if pleural fluid is drained in a spontaneously breathing patient, the net improvement in oxygenation is somewhat relatively minor. Second, if the chest wall of a mechanically ventilated patient is less compliant and does not adequately expand to buffer the excessive fluid volume, then increasing the peel or applying recruitment maneuvers in this situation is less likely to open up the collapsed alveoli. Under such circumstances, pleural fluid drainage rather than ventilator adjustments are more likely to improve the physiology. Nevertheless, the removal of pleural fluid may still improve breathlessness by other mechanisms, mainly by improving respiratory muscle efficiency. In mechanically ventilated patients, this might sometimes accelerate weaning, even though the oxygenation status itself may not show any great change. Lastly, circulatory impairment from pleural fluid collection is rather infrequent and usually minor. So how is a therapeutic pleural fluid drainage likely to benefit a spontaneously breathing patient? From a physiological standpoint, fluid drainage can reduce the compressive atelectasis of the adjoining lung, thereby improving local ventilation perfusion relationship. Fluid removal also offers better mechanical advantage to the overlying respiratory muscles. Restoration of near normal intrapleural pressures will also allow better mechanical coupling between the lung and the diaphragm, and there is also lesser stimulation of the pulmonary stretch receptors. All of this in combination can translate into somewhat lesser work of breathing for the patient. This reduction in work of breathing alone can reduce the sensation of breathlessness in these patients, even without any corresponding significant improvement in oxygenation. The impact of pleural fluid drainage might be slightly different for mechanically ventilated patients. Fluid removal can definitely improve the respiratory mechanics as in non-ventilated patients. But as we pointed out earlier, this may not be directly proportional to the volume of pleural fluid removed. Additionally, oxygenation might still improve over time in a sustained manner because of improvement in ventilation perfusion matching. However, clinical studies in ICU patients have not shown that fluid drainage has a consistently positive influence on duration of mechanical ventilation or on the ICU or the hospital length of stay. So a few studies have evaluated the clinical impact of pleural fluid drainage in ICU patients, and two meta-analyses are available on this topic. This initial meta-analysis was performed more than a decade ago and summarized information from 19 such observational studies conducted on mechanically ventilated patients. Of these, some studies measured physiological or clinical effects of pleural fluid drainage, while others assessed its safety. So 5 studies included in this meta-analysis looked at changes in PO2 to FiO2 ratio after fluid drainage. So there was considerable heterogeneity in the findings, and this probably was due to differences in severity of, say, pre-existing hypoxemia or lung and chest wall mechanics and PEEP settings and pleural fluid volumes and so on and so forth. So the summary absolute improvement in PO2 to FiO2 ratio was about 30. And this had really a wide confidence interval. So even though this improvement looks statistically significant, this is clinically a rather small improvement in oxygenation. The pooled complication rate from pleural fluid drainage was low. Overall, 3.4% procedures in 965 patients resulted in pneumothorax, while hemothorax was reported after 1.6% of 721 procedures. The use of ultrasound guidance, either real-time or for site marking, was not associated with any significant reduction in risk of pneumothorax, possibly because most such effusions were moderate or large. More recently, another meta-analysis published in 2019 has reviewed these and other outcomes in both ventilated and non-ventilated patients in the ICU. In this meta-analysis, the PO2 by FiO2 information was available from 9 studies. More than 85% of the included patients in this meta-analysis were on ventilator. So pooled data again suggested that there is a statistically significant improvement on oxygen status after pleural fluid removal with a moderate overall effect size, because the standardized mean difference is between 0.5 and 0.8. A very small number of studies also looked at other outcome parameters, and there was a statistically significant improvement in end expiratory lung volume after fluid drainage, but none in the alveolo-arterial gradient. Similarly, the hemodynamic parameters also did not change appreciably. The minor improvements in heart rate, blood pressure, left ventricular end diastolic volume, stroke volume, cardiac output, or ejection fraction were all statistically insignificant. The pooled complication rate from pleural fluid drainage was reported even lower than in the previous meta-analysis. Overall, only 0.8% procedures in 1513 patients resulted in a pneumothorax, while hemothorax occurred in only 0.1% of the nearly 1100 procedures. So this meta-analysis again found no statistically significant differences in complication rates between ventilated and non-ventilated patients, or between adult and pediatric patients. So it appears that while pleural fluid drainage is safe in critically ill patients, the clinical benefits are rather variable and not as substantial as is widely believed. Hence, we need to choose patients carefully and consider therapeutic drainage only among those who are likely to benefit the most. Those having significant lung collapse due to massive pleural effusions are more likely to improve than those with smaller fluid collections. Also, as I pointed out earlier, patients with reduced chest wall compliance can derive some benefit from pleural fluid drainage. Some of the clinical indicators for reduced chest wall compliance include gross obesity, presence of kyphosis or other spinal deformities, coexisting neuromuscular weakness, and or presence of moderate or large ascitic fluid. Fluid removal is likely to be significantly beneficial only if there is no concomitant major reduction in lung compliance. For instance, patients having lung consolidation or those having lung malignancy are more likely to have a reduced lung compliance. Here, I would also like to emphasize that it may often be necessary to properly recruit the underlying atelectatic lung after fluid removal, especially in mechanically ventilated patients. These patients may benefit from temporary increment in applied PEEP to assist lung expansion and sustain the improvement in oxygenation after fluid removal. So this is one proposed algorithm for the management of pleural effusion for gas exchange considerations in mechanically ventilated patients who are also having acute respiratory failure. The assessment of chest wall compliance may help in deciding whether to therapeutically drain a pleural effusion or not. Formal estimation of chest wall compliance requires esophageal pressure measurement, which is perhaps not really widely available. Clinically, in the critically ill patient, reduced chest wall compliance frequently results from an abdominal pathology and or fluid overload with associated chest wall and visceral edema. If chest wall compliance is thought to be reduced or proven to be reduced, then some lung collapse from pleural effusion is to be expected. So increasing PEEP may be ineffective in offsetting this, and pleural drainage is therefore likely to be beneficial. If the chest wall compliance is measured or considered to be normal, then a lung recruitment maneuver may help in decision making. If no benefit results from this recruitment maneuver, then lung collapse due to effusion is probably minor, and drainage for gas exchange improvement alone may not be warranted. However, if the static compliance of the respiratory system and or the oxygenation improved during and immediately after the recruitment maneuver, increasing PEEP can somewhat offset the lung collapse that we attribute to pleural effusion. Alternatively, in this setting, pleural fluid drainage could reduce the PEEP level needed to sustain such recruitment, and again a therapeutic pleural trap which would probably be considered. And finally, which chest drain to use for this purpose? In general, wide bore chest tubes are more effective for draining thick empyema fluid or for evacuating a hemithorax, as they are less likely to get blocked under these circumstances. However, they are slightly uncomfortable for patients. Hence, in all other settings, smaller bore tubes such as pigtail catheters are generally preferred. If the fluid is not thick or bloody, then these thinner tubes are much more comfortable for the patient, while being equally efficient in comparison to the larger bore drains. Irrespective of the chest drain used, fluid must always be removed through an underwater sealed drainage system to maintain integrity and mechanics of the pleural space. To summarize, pleural effusions are frequently encountered among critically ill patients. Depending on etiology, underlying patient condition, and the volume of pleural fluid, this might have a variable impact on clinical status and gas exchange in these patients. Most pleural effusions are small, uncomplicated, and likely to resolve on their own without any active intervention. Only few patients will need a diagnostic pleural tap, mainly if the pleural infection or hemothorax is suspected, or if there is no clarity on the underlying etiology. Ultrasound should be routinely used to guide such diagnostic aspiration. Similarly, only a few patients will need therapeutic pleural fluid drainage, but not all of them will show a corresponding clinical or physiological improvement. This flowchart summarizes the key action points for the intensivist. Any pleural effusion in a critically ill patient should always be confirmed through reliable imaging. If the effusion is massive or is associated with respiratory compromise, or if it is obviously infected, or if the patient has hemothorax or a hydropneumothorax, one can directly consider a therapeutic pleural fluid drainage. Small effusions with no respiratory compromise, then especially if there is no reason for, if the reason for effusion is not obvious, then these patients can sometimes be safely observed. In such cases, we can treat the underlying disease and reassess for need for intervention in case of any clinical worsening. A diagnostic pleural tap might be necessary if the etiology of the underlying effusion is not obvious. If we tap transudative fluid, then we just need to correlate this with the underlying clinical features and manage accordingly. If the pleural fluid is exudative, then we need to decide regarding the need for therapeutic drainage. A low pleural fluid pH in this setting will more or less suggest underlying infection, and then this is often considered as a single best parameter to consider pleural drainage. In case pH is not available, then as I said, low pleural fluid sugar or a very high LDH level can also be used as a surrogate. However, if the pleural fluid pH is above 0.7 or 0.20, then drainage might not be indicated. And again, we need to tackle the underlying disorder. So thank you for your attention. And I'll be happy to take up a few questions.
Thank you, Ashu. Can you please stop share screen? So is the video on, Ashu? Okay, great. So thank you. Thanks a lot. Very nice and informative, especially the role of pleural effusion in reducing oxygenation. Very nice strategy you have shown. Now, just a couple of things, if you can clarify for our audience, Ashu. What about the role of ADA in tubercular pleural effusions? Is it reliable enough, or what is your experience?
So ADA is a kind of frontline investigation for tuberculosis. Tuberculosis generally is not a consideration in the ICU once the infection is suspected in these patients. So in that setting, if you have say a low ADA, then it is often considered that you can more or less reliably exclude tuberculosis in this patient. But if you have a high ADA, then I think you need to consider it along with other clinical parameters, history, and say a lymphocytic exudative effusion, or if there is a history of say a positive PPD skin test, and the pleural fluid is lymphocytic, then all these parameters together you can maybe sometimes use to diagnose tuberculous pleural effusion on clinical grounds. So
cutoff of 40 is okay as recommended?
So cutoff of 40 is generally for negative, it has a good negative predictive value. So at ADA value which is less than 40 will practically rule out tuberculous effusion. But if you want positive diagnosis, then you should more or less aim for a slightly higher value, say 70. So any pleural fluid ADA that is higher than 70 is more likely to be related to tuberculosis, and the gray area lies between 40 to 70, which you generally need to tackle on clinical basis or using a composite reference standard.
Once we had a patient who had an extremely high ADA, turned out to be a lymphoma actually.
So, yeah, so false positives are fairly common.
Okay, so coming to the other thing, you talked about the X-ray picture on the supine film, right? So you showed a lot of things, and just one question, in the PA view, we look at the CP angle blunting. So where does the CP angle blunting stand in the supine film? I mean,
So CP angle blunting is generally not visible in the supine film because the fluid tends to layer posteriorly. So first it will go into the posterior gutter. So it goes behind the diaphragm. And therefore you will not see it really in that sense. As the effusion increases, it tends to layer out. So that classical CP angle blunting, I also showed you a graphic for that. So that typical meniscus sign and rising fluid level is not seen. So that rising fluid level, if it is very small, is usually the sign for CP angle blunting. So, but generally in a supine film, that may not be visible.
So would it also depend on the volume? Larger volumes would probably have the...
So larger volume will again cause more haziness. And if the fluid volume is actually large, then the diaphragmatic ciliate can be completely obliterated. So in that sense, that typical CP angle blunting sign, it is a sign in a erect film. In a supine film, it generally is not seen.
Great. So the other thing you talked about was the visuality of bronchovascular markings below the layering out of the fluid, isn't it?
Yeah.
That helps in distinguishing it from a pneumonia also. Because if there's a because of pneumonia, you won't see bronchovascular markings in the
Yeah. It will look more dense. You might even see an air bronchogram.
Yeah. So that is how you distinguish. Yeah. So
yeah, it's not 100%, but it's a good clinical sign.
So just then moving on to hepatic hydrothorax. I think this is a common problem, ascites with hepatic hydrothorax. So just like to tell the audience one thing, that very rarely you may not have ascites in the setting of cirrhosis. They may just come up with an effusion. That is also possible. This is quite rare, but it happens because cirrhosis coming to the ICU is very common. And the other thing I would like to tell the audience is kindly do not put chest tubes for these hepatic hydrothoraces. One-time drainage should be done because there's a risk of, if you put a chest tube, then they continuously drain proteins and electrolytes. And secondly, there's always the risk of bleeding. This is much bigger. The tubes are much bigger. You create a hole, and even if you don't induce bleeding while putting it, when you remove it, there can be bleeding because the coagulation may have altered by that time. And we have had this problem, and neither is this recommended. Some people do put in chest tubes and all because these effusions don't go away, and you have to manage the ascites actually. So the correct management is one-time drainage or repeat the drainage, one time repeat it again, but don't put chest tubes, and manage the ascites with salt restriction, aldactone, and Lasix. So that is the way you have to manage hepatic hydrothoracics. And
so I can add to that.
yeah.
So because in spontaneously breathing patients, the intrapleural pressure is negative, so it literally sucks out the ascitic fluid into the pleural cavity through small diaphragmatic defects. And if you put in a drain, you are actually draining the ascites through the pleural cavity. So that is the point, and therefore it never goes away. So if you really want to have an effective drainage, then what we sometimes do is we apply CPAP. So application of CPAP will make the intrapleural pressure slightly positive, and it will not therefore allow the ascitic fluid to enter the pleural cavity. And then we can attempt a pleurodesis, a chemical pleurodesis, by instilling, say, betadine or talc into the pleural cavity, and keep the CPAP pressure on for 4 to 6 hours, so that the fluid does not re-enter the pleural cavity, and then try and see if pleurodesis occurs. And we have used this in some of our patients, and this is a well-described technique of managing refractory hepatic hydrothorax by causing pleurodesis so that the fluid is unable to enter the pleural cavity.
So the pleurodesis should be attempted after enough drainage, or do you do it with the fluid also? I mean,
so drainage is never enough in hepatic hydrothorax. You put in a tube, it continues to drain. So even if it is draining, it does not matter. You apply positive pressure, so the ascitic fluid will not move on into the pleural cavity. So ascites will keep on accumulating. That you can manage separately. But at least the pleural effusion will not develop, because then these patients end up with respiratory distress and all that. And in any case, once the hepatic hydrothorax develops, then these patients should also be put on a transplant list. So that is the definitive management for hepatic hydrothorax, the liver transplantation.
So then a word about chylothorax. Sometimes after these esophageal surgeries or mediastinal surgeries, occasionally patients develop chylothorax. So any comments on chylothorax, Dr. Ashu?
So chylothorax is a pretty difficult problem to tackle. So very often in the post-op setting, you can see it and you can relate it to injury of the thoracic duct. And the fluid which collects is it keeps on collecting. So you keep on draining, it keeps on collecting. Octreotide is one method by which you can reduce the fluid collection. You can try it. And secondly, you have to use certain dietary modifications. In general, for some of our patients, we have used nuclear medicine techniques to try and identify the leak in the thoracic duct. And if such a leak can be identified, then our surgery colleagues have once in a while helped us in trying to seal that leak. But otherwise, I agree it's a pretty difficult problem to manage.
Yeah, but sometimes we have seen this spontaneously stop also. I mean, we had some.
Yeah, they will. Especially post-operative ones, they will spontaneously stop several times.
And the diagnosis is on the basis of triglycerides more than a value of 110.
Yeah, yeah.
So other thing is, what about tubercular effusions? You know, because it's not so common to get tubercular effusions in the ICU in different settings. So is it right to say that generally they are unilateral, by and large 90%, unless it's complicated by hypoalbuminemia or causative pericarditis, tubercular effusions?
Yeah, mostly, as you said, almost 80 to 90% of effusions will be unilateral. Even we come across bilateral effusions only once in a while. So unilateral, moderate size effusions, that is the most common presentation.
Because they are not so uncommon in the ICU in different settings, because tuberculosis is rampant. So then moving on to ARDS. So ARDS patients often develop effusions, as we have seen, as you know, and as far as evidence is concerned, in what to do with these effusions. So there is no clear-cut consensus whether they should be drained or not to be drained. And evidence of inducing pneumothorax is more. So one has to have a clinical judgment as to whether they should be drained or not to be drained. Pleural effusions with ARDS. And definitely there can be some improvement in oxygenation, and you have shown the data also. It may not be so much, but definitely it helps in weaning because the work of breathing does go down, especially if the effusions on the larger side. And the other thing is, if there is an effusion, you can go higher on the plateau pressure because the pleural pressure is higher. So if the pleural pressure is higher, you can increase the plateau pressure beyond 30 because the transpulmonary pressure would be higher in these patients otherwise. So that way you can increase the plateau pressure if there's a pleural pressure in ARDS patients. So anything you want to add to that?
No, not exactly, but as I showed in one of the algorithms, chest wall compliance is a major determinant here. So if your chest wall compliance is normal, then a lot of the effusion is actually buffered in the pleural space, and so that is the only consideration. So if the chest wall compliance is abnormal, or it is believed to be say in obesity or neuromuscular weakness or some skeletal deformities, then the pressure changes on the lung are likely to be more significant, and these patients in particular might benefit more from a pleural fluid drainage.
Right. And now just finally coming to CHF. So like shown in CHF, the effusions are generally bilateral, or the right can be more than left. However, if there is a gross discrepancy or if the left is more than right, then you have to think of an alternate cause. And I think should be investigated, and another etiology should be sought in CHF patients because these are again very common CHF with effusions. So any comment, Ashok?
Yeah, I think I by and large agree with you. CHF is believed to be one of the commonest etiologies of pleural effusion in the ICU, and small bilateral effusions that typically do not require any intervention, just the management of the underlying cardiac dysfunction.
Right. So I think there are no questions. And one more thing before I come to a conclusion is that everybody should know the Lights criteria. I mean, that is still the most widely used. Sir has not elaborated because it's there in all the books. But to diagnose and differentiate between transudative and exudative, all of you should know the Lights criteria. That is very important. So that was about it. So anything else you want to add, sir?
No, nothing. By and large, I think that more or less covers it.
Okay, great. So thank you so much, Dr. Agarwal, sir. Very nice of you to have spared your time and spoken to our intensivist. And hopefully see you again. There are no questions. See you again with some other topic in the near future. Thank you very much, sir.
Okay, thanks, Apesh.